Before we get into this week's episode, we'd just like to make a correction to last week's episode. In our previous episode on the difficult caesarean section, we sung the praises of the good old fetal pillow. Since then, our wise listener, Dr. Abigail Anderson, has informed us that there was actually an update to the Greentop Scientific Impact paper number 73, Management of Impacted Fetal Head at Caesarean Birth, in June. One of the key papers on fetal pillows was retracted in June, meaning that updated meta-analysis are needed to determine how useful the fetal pillow actually is. As a result, the ARCOG advises caution when reviewing the data regarding the benefits of fetal pillow. Thank you, Abigail and the team at Townsville University Hospital for keeping us all up to date. Hi, I'm Carla Pecoraro.
I'm Anne Woolfield.
And I'm Mel Akerman, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information on all things O&G. It is time for another episode of Evidence with Anne, where we discuss RANZCOG landmark trials and other important research that guides how we practice.
I'm sure you're so excited.
I know I am. Today, we are going to discuss magnesium sulfate and its use in the prevention of eclampsia and for neuroprotection in the preterm fetus. There are two RANZCOG landmark clinical trials, the MAGPIE trial and the Cochrane review, Magnesium Sulfate for women at risk of preterm birth for neuroprotection of the fetus. We will also chat about the new Magenta trial, only recently published this year in the JAMA.
So, magnesium sulfate has a pretty interesting history. It was first administered by intraspinal injection to treat non-obstetric seizures, which led to obstetricians deciding to try magnesium sulfate for eclamptic seizures in the early 1900s. At the time, eclamptic seizures had a 20 to 30% mortality rate, and the use of MAG-Sulf to treat eclampsia resulted in a drop in maternal mortality to 5%. The first published case reports on the use of MAG-Sulf were released in 1924, which means we're coming up to 100 years of using MAG-Sulf. Over the next few decades, magnesium sulfate was used regularly in the treatment of eclampsia, but often with other anticonvulsant therapies, making it difficult to determine how effective MAG-Sulf was on its own. The first trial demonstrating the efficacy of MAG-Sulf on its own was actually done by Pritchard in 1950, and since then there have been plenty of randomized controlled trials looking at the role of magnesium sulfate in the prevention of eclampsia. But by far the biggest is the MAGPIE trial.
And it's also sweeping season, so it's very timely. Does anyone else actually think of magpies when this trial is mentioned?
Yes, definitely. They're an Australian icon.
Agreed. All right, Anne, tell us all about the MAGPIE trial.
The trial is called Do Women with Preeclampsia and Their Babies Benefit from Magnesium Sulfate? The MAGPIE trial, a randomized placebo-controlled trial. It was published by Altman and the MAGPIE Trial Collaborative Group in The Lancet in 2002.
The aim of this trial was to evaluate the effect of magnesium sulfate on women and babies in those with preeclampsia and to see if they do better with magnesium sulfate, regardless of if it was started before or after delivery and with or without anticonvulsant therapy.
It was a multi-center, placebo-controlled, randomized control trial. It was set in 33 different high, middle, and low-income countries between 1998 to 2001. If you think of strengths and limitations, this is a great strength, improving its generalizability globally.
So, the MAGPIE trial was a multi-center, placebo-controlled RCT, published in The Lancet in 2002 by Altman and the MAGPIE Trial Collaborative Group. All these acronyms. MAGPIE stands for magnesium sulfate for the prevention of eclampsia. And who were the participants? Who was eligible for entry into this trial?
The WHO. So over 10,000 women. Yes, you heard me correctly. Over 10,000 women who had not yet given birth or were 24 hours or less postpartum, who had preeclampsia, and there was clinical uncertainty about the use of MAG-Sulf. Most women were recruited in the labour ward, and preeclampsia was defined as a blood pressure of 140 on 90 or more and proteinuria.
Mel, what were the exclusion criteria?
There are a few important contraindications to MAG-Sulf, and these were some of the exclusion criteria. These include an allergy to magnesium, myasthenia gravis, or hepatic coma with a risk of renal failure. Fun fact, Magnesium sulfate is contraindicated in myasthenia gravis because it acts at the neuromuscular junction and potentiates muscle weakness. People with myasthenia gravis can actually go into complete respiratory failure requiring ventilation if we give them magnesium.
The intervention used in the MAGPIE trial is the same magnesium sulfate regime that we routinely use, a loading dose of 4 grams of MagSulf over 10 to 15 minutes, then 1 gram per hour maintenance. Or there was an intramuscular protocol as well. Hopefully, this makes it nice and easy to remember. There was also an emergency pack included to use in the event of eclampsia. This was essential because it included the correct dose of MagSulf that was required for eclampsia depending on if the patient was randomized to treatment or placebo.
Thank goodness for that. So women with preeclampsia during labour or in the 24 hours postpartum were randomized to magnesium sulfate loading and maintenance doses or placebo. So what was the primary outcome?
The primary outcomes were eclampsia, and for those randomized prior to delivery, death of the baby. Mel, what were the secondary outcomes?
The secondary outcomes include serious maternal morbidity, toxicity, side effects, complications of labour, and neonatal morbidity.
Maternal morbidity included respiratory depression, respiratory arrest, pneumonia, cardiac arrest, coagulopathy, renal failure, liver failure, pulmonary edema, and cerebral hemorrhage. I like to think of it as just every single organ failure.
Side effects included things like nausea, vomiting, flushing of the skin, drowsiness, confusion, muscle weakness, and abscess.
Complications of labour included induction of labour, length of labour, transfusion, and gestation at delivery.
And lastly, neonatal morbidity included APGARs less than 7 at 5 minutes, intubation at the place of delivery, ventilation, abnormal cerebral ultrasound, convulsions, and admission to the special care nursery.
And I'm really hoping you have an extremely long acronym because that is a lot of secondary outcomes and I've absolutely forgotten every single one and what the primary outcomes were. Help!
So the primary outcome were eclampsia and antepartum or intrapartum fetal death. The analysis was done as intention to treat and were analysed by subgroups. These subgroups included the severity of preeclampsia, imminent eclampsia, gestational age, and whether they had an anticonvulsant in the previous 48 hours.
All right. So now that we've described the trial, give me the juicy details. What were the results?
Well, there was a 58% reduction in the risk of eclampsia. Amazing.
Woo-hoo!
There were 11 per 1,000 women fewer who'd had eclampsia. The number needed to treat was 91, but this was only 63 in those with severe preeclampsia. Maternal mortality was also lower in women who received magnesium sulfate, although there was no clear difference in the risk of the baby dying.
Wow, now there is a stat to remember. Magnesium sulfate halves the risk of eclampsia. There was also a reduction in placental abruptions as well, with a relative risk of 0.67, and there were no harmful effects to the mother or baby.
Unsurprisingly, there were significantly more side effects in the magnesium sulfate group. We all know how poorly these women feel when they're on magnesium. I guess that does limit the true blinding ability of this intervention. For those studying who have studied for their exams, what is the medication that we always say precaution with use in conjunction with magnesium sulfate?
Nifedipine, or as my medical student calls it, nifedipine. Sorry, buddy. Now, we mainly try and use caution with nifedipine with magnesium sulfate because we're worried about the compounding effect of hypertension, but also the increased risk of magnesium toxicity.
So interestingly, 30% of the patients in the MAGPIE trial had both nifedipine and magnesium sulfate, and there was no adverse effects.
Wow, there you go. All right, summary time. The MAGPIE trial is titled, Do Women with Preeclampsia and Their Babies Benefit from Magnesium Sulfate? The MAGPIE trial, a randomized placebo-controlled trial. It was published by Altman and the MAGPIE Collaborative Group in The Lancet in 2002. The aim of the trial was to determine whether women with preeclampsia or their babies do better with magnesium sulfate or with placebo. And it was a multi-country, multi-center, placebo-controlled RCT done between 1998 and 2001.
Over 10,000 women with preeclampsia who were pregnant or within 24 hours of delivery were randomized to either MagSulf or placebo. Patients were excluded if they had hypersensitivity to magnesium, hepatic coma, or myasthenia gravis. Primary outcomes included eclampsia and fetal death, and secondary outcomes included serious maternal morbidity, toxicity, and side effects, as well as complications of labor and neonatal morbidity.
And the results showed that magnesium sulfate reduced the rate of eclampsia by 58%. The MAGPIE trial had a great study design and it recruited women from both high and low income countries, making, once already said, the findings very generalizable. It had a large sample size, which increases the power of this study. And importantly, this trial clearly demonstrated that magnesium sulfate decreased the risk of eclampsia from preeclampsia without causing any negative effects to babies, and it provided a regime. This trial is what we base our current dosing of magnesium sulfate off.
Such a good trial. Okay, let's move on to the next RANZCOG landmark trial, looking at magnesium. So, we know that magnesium sulfate is useful for the prevention of eclamptic seizures in preeclampsia, but how did we work out that it can also be used for neuroprotection for infants? Mel, take it away.
Okay, time for another history lesson. So, the first suggestion that magnesium sulfate might be useful for prevention of cerebral palsy came from a case-control study by Nelson and Grether in 1995 that investigated whether antenatal exposure to MagSulf amongst very low birth weight infants was associated with a decreased incidence of cerebral palsy. They basically looked at 3-year-old children who were born weighing less than 1.5 kilos with a diagnosis of cerebral palsy and compared them with a randomly selected group of very low birth weight children who did not develop cerebral palsy. Essentially, they found that children with cerebral palsy had less frequent in utero exposure to magnesium sulfate when compared to the control group. This obviously generated enormous interest and subsequently led to the development of several large randomized control trials to further investigate this hypothesis. Now again, there are heaps of trials looking into this, all of them with mag in it. Magnet, Actum GSO4, so like Actomagsulf, Premag, and Beam, for example. So naturally, that brings us into the next landmark trial, a Cochrane review published by Doyle in 2009 called Magnesium Sulfate for Women at Risk of Preterm Birth for Neuroprotection of the Fetus.
So this was a systematic review and meta-analysis. The aim of this review was to assess the effects of magnesium sulfate as a neuroprotective agent when given to women at a risk of preterm birth.
This review combined 5 different trials, a total of 6,145 babies. The 5 trials were the MAGPIE trial, we've already chatted about, Actomagsulf, set in Australia and New Zealand, Premag from France by Marit in 2006, the Beam trial by Rouse in the US in 2008, and the Magnet trial, also in the US by Mittendorf in 2002. Except for the MAGPIE trial, these trials were designed to assess the use of magnesium sulfate as neuroprotection for those likely to have a preterm birth. The Magnet trial also had a tocolytic arm.
Okay, so with lots of different trials, what was the gestation used? I know we give MagSulf for those likely to deliver before 30 weeks gestation, based on our local guidelines. Is that the cutoff used in these trials?
That's a very good question, Carla, and one I spent a lot of time looking into. Essentially, no. There were a few different gestations that were included, including below 37 weeks, between 24 and 32 weeks, and below 30 weeks.
Okay then, time for a little recap. The RANZCOG landmark trial, Magnesium Sulfate for Women at Risk of Preterm Birth for Neuroprotection of the Fetus, is a Cochrane review published in 2009 by Doyle et al. It included 5 trials, Premag, MAGPIE, Actomagsulf, Beam, and Magnet, which included over 6,000 babies. And what were the primary outcomes? What do we mean when we say neuroprotection?
We'll get to what we mean by neuroprotection when we get to the results. But the primary outcome for this review was death, neurological impairment, and major neurological disability. For the women, the primary outcome was a serious adverse effect.
There were many secondary outcomes. For the woman, these included observations, labour, augmentation, PPH, intrapartum fever, breastfeeding, and women's satisfaction.
For babies, this included intraventricular hemorrhage, periventricular leukomalacia, APGARs, active resuscitation, seizures, hypertonia, respiratory support, chronic lung disease, educational achievements, and growth.
And for the use of health services, these secondary outcomes included maternal and infant admissions, length of stay, and cost.
Finally, we can get to the good stuff. What were the results, Anne?
When magnesium sulfate was given to women at risk of preterm birth, there was a reduction in cerebral palsy and gross motor dysfunction. This is what we mean by neuroprotection, a protection against cerebral palsy and gross motor dysfunction.
Thus, the risk of cerebral palsy in those in the magnesium group was 3.7% versus 5.4% in the placebo group, a reduction of 1.7%. The total number needed to treat was 63. Importantly, there was no significant effect on pediatric mortality or other neurological impairments in the first few years of life. This is important because we want to make sure the reduction in cerebral palsy isn't because those babies with cerebral palsy are actually dying because of magnesium sulfate.
And if you prefer your numbers in relative risk form, the relative risk of cerebral palsy in the magnesium versus placebo groups was 0.68, and the relative risk of gross motor dysfunction was 0.61.
Far out, amazing. Magnesium sulfate is neuroprotective, with a reduction in cerebral palsy of 1.7%, from 5.4 to 3.7%, and the number needed to treat was 63.
It's a bit of a wonder drug, isn't it? We use MagSulf for eclampsia, we use it for neuroprotection. Pretty cool. All right, Carla, hit us with a quick recap.
Okay. Magnesium sulfate for women at risk of preterm birth for neuroprotection of the fetus is a Cochrane review published in 2009 by Doyle et al. It included 5 trials: PreMag, MAGPIE, Actim MagSulf, Beam, and Magnet, which included over 6,000 babies. Primary outcome for this review was death, neurological impairment, and major neurological disability. And the outcome was that antenatal magnesium sulfate given to women at risk of preterm birth reduced the risk of cerebral palsy by 1.7%, 5.4% versus 3.7%, or a relative risk of 0.68, with a number needed to treat of 63. It also reduced the risk of substantial gross motor dysfunction with a relative risk of 0.61, and there was no significant effect on pediatric mortality.
I found this paper a really interesting read, although it is incredibly long with all the graphs. The trial design using the meta-analysis was a great way to increase the power of this data. I did find it difficult for me to know how to apply this in the context of different gestation cutoffs for each study. Spoiler alert, this leads us nicely into our next trial.
Yes, the Magenta trial. We have been waiting for this to be published for such a long time.
Yeah, I remember when we did the Preterm Birth podcast, we were wondering when it would be published, and here it is.
Okay, so what is the Magenta trial?
So, the Magenta trial was specifically looking at the effect of magnesium sulfate as a neuroprotective agent for women between 30 and 34 weeks gestation. This is because previous trials showed a clear benefit in babies under 30 weeks gestation, but the data was less clear for babies above 30 weeks, meaning we had this weird gestational period from 30 to 34 weeks where guidelines would say we could consider magnesium sulfate, but wouldn't really commit to whether we actually should or not. The official title of the trial is Prenatal Intravenous Magnesium at 30 to 34 weeks gestation and Neurodevelopment Outcomes in Offspring, the Magenta Randomized Clinical Trial. It was published by our new favorite person, Caroline Crowther et al. In August 2023 in JAMA.
In the conduct of the trial, there was a data and safety monitoring committee and no interim analyses were undertaken. The WHO, so the participants included those expected to deliver at 30 to 34 weeks gestation within the next 24 hours.
It excluded those who had contraindications to magnesium and in those women who needed it for preeclampsia.
It was a multi-center, double-blind, randomized control trial. It was conducted in 24 different hospitals in Australia and New Zealand between 2012 and 2018.
So let's have a recap. The Magenta trial was a multi-center, double-blind RCT that was published in August 2023 by our favourite new person, Crowther in the JAMA. It included women who were 30 to 34 weeks pregnant where delivery was expected within 24 hours. What was the intervention? The same magnesium sulfate dose?
Nearly the same. It was just a once-off 4 grams of magnesium sulfate over 30 minutes, but without the maintenance dose.
And what were the primary outcomes?
Stillbirth or death of the child up to 2 years, or cerebral palsy at 2 years of age. There were heaps of secondary outcomes, and I'm not going to list them all here.
All right. Don't keep me waiting. What were the results?
Disappointingly, there was no difference in the primary outcome. Death or cerebral palsy at 2 years was not different between those that received magnesium sulfate or placebo. This means that the evidence does not support giving magnesium sulfate to those at risk of preterm birth above 30 weeks, gestation for fetal neuroprotection.
There were a few significant results from the secondary outcomes. In the magnesium group, the babies were less likely to have respiratory distress syndrome and chronic lung disease.
And for the mum in the magnesium group, they were less likely to have a caesarean, but slightly more likely to have a PPH. There were no significant adverse events. From a study design perspective, they did stratify by hospital and gestational age. I also liked that once again, it was double-blinded. A comment in the conclusion was that it might not have had enough power to detect a small difference because the rate of the primary outcome was lower than expected.
It's disappointing that magnesium sulfate doesn't seem to be helpful for those babies born over 30 weeks, but it is good to have some concrete data on the topic though. While we do want more treatments to reduce cerebral palsy in babies, we don't want to be administering medication that doesn't actually help. Hopefully our Australian guidelines will be updated to reflect this study and we can clearly use 30 weeks gestation as our cutoff for giving magnesium sulfate.
And that's it, folks. We hope you've enjoyed our discussion on the evidence behind magnesium sulfate in the use of prevention of eclampsia and for the neuroprotection of babies born preterm. Thanks for listening to the Uterine Sound. Check us out on Instagram at the Uterine Sound or email us at theuterinesound@gmail.com. Visit our website, theuterinesound.com. Let us know if you have any questions, queries, or want to fact check us.